Okay, everyone, we're going to get started. Colleen, I just wanted to be sure that this is going to record automatically, or if I have to do anything,
Yep,
let me know.
it does. I don't know. Can you hear me?
I do hear you.
Oh, okay. I better mute my line then. Okay. Yes, it will record automatically.
Very good. Okay, to everybody else out there, welcome. I have attempted to mute everyone upon entry, but I've lost some of that control. So I do hear a lot of background noise. If you could please mute yourselves if you are not muted automatically, I would really appreciate it. And
Tim,
we are going...
You have to keep hitting mute on entry over and over again. It only lasts for like 10 seconds.
It does that drop down. Colleen, that drop down isn't showing up any longer.
Okay, let me see what I can do.
So I don't know what happened there.
I think you're good.
Why don't you try it? Because maybe it took you over as host.
Yeah, I put mute all. Are you still there?
I'm here.
Go ahead. I think we're good.
Okay. Well, welcome, everyone. I appreciate all of you making time to be here today. We know that we are living in a crazy time, and all of you from pharmacists, technicians, 340B coordinators, C-suites, everyone is operating well out of their comfort zones, but you guys are doing a fantastic job. So please keep it up. We're so grateful to all of you for what you do. Today, for office hours, we are going to run through a couple of operational updates, and then Jengis Whitner is going to present on staff education as far as 340B. This has been something that we've seen a lot of questions on Nattopod and such, and he was willing to put this together. I think you'll really enjoy his presentation today. So let's go ahead and jump right into the operational updates. First of all, site registrations. As community health centers, we have always had kind of a little extended window. OPA, HRSA has been good to us. You all know that the normal registration for contract pharmacies and for sites ended yesterday. We generally get an extension, and I just looked that up. The one that I saw from HRSA back on the 2nd of April, we'd have through May 22nd to register sites. We'd have to go through the special process of calling up Texas and everything. HRSA, though, has announced that they will allow immediate enrollment upon request and review. This kind of means if you have a specific reason, and this isn't just health centers, this will be for hospitals, Ryan White's, other grantees or designees, that they're going to be working with everyone because of the times that we're in order to get sites registered. So if you need more information on that, the items in green on this slide are hyperlinks. So these slides are posted on Nattopod, and if they're not already, they'll be posted on NAC's 340B website or webpage. So you'd have access to this. If for some reason you can't get it, just reach out to me and I'll send you the links. But as standard, we have until May 22nd, but they may open it up even longer if we're still dealing with some significant issues with COVID-19 past that date. .340B universities. We are talking about the end of August, and all of us are hoping and praying that our lives will be back to normal and that next CHI conference will go on in San Diego as has been planned. There will be a 340B university there, and the beauty of this, it's strictly on community health center and how 340B relates to us. It does not include hospitals or Ryan White's or Soul Community Hospitals or anything else. It will just be community health centers. And it's wonderful because all of the Apexus staff, all of the speakers are able to focus their remarks just on what's going to apply to us. So We're going to keep our fingers crossed that this will continue, that the event will continue to be held, and the university is free, but you do have to pre-register. Generally, Apexus puts that out roughly 2 months, 60 days or so ahead of time. I'll be keeping an eye on that. As soon as it's available to register, I'll post on Noddlepod so that you'll all know. This is another topic that I've been getting emails on. We've discussed it on Noddlepod, but I thought it would be good to review it for the entire body today. Telehealth and 340B. The understanding now that I have is that we can use 340B for prescriptions authorized or written via telehealth, so long as we meet the normal constraints, which is that the employer is, or the prescriber is employed by or under contract with the health center, that there are good medical records of that telehealth visit, and that it's within our scope of project. So if we're meeting those, the telehealth visit would qualify to make those prescriptions 340B eligible. Derek Peel was kind enough to let me copy off something that he had posted, and I like his language here because it's real simple and it encompasses and leaves it kind of open for interpretation for us. So under their 340B eligible patient definition policy, they changed it slightly to say that healthcare services means in-person or telehealth visits, including either video or telephone, with a healthcare professional. It's all-encompassing, and it removes any kind of doubt of whether or not the telehealth visit is viewed as a eligible visit and a 340B eligible visit as well. There has been so much that has come out from the American Pharmacy Association, and I'm a member of that, so I've been getting a lot of additional things. I try to post them on Noddlepod because I think they're important to the directors of pharmacy and the staff pharmacists and the others within the pharmacy. So I've included some hyperlinks here. We do know that pharmacists are considered healthcare professionals and will be allowed to do COVID-19 testing. APHA offers a free educational webinar on specimen collection for COVID-19. There is no charge whether you're a member or not. They also put out NCPA, the National Community Pharmacists Association, put out a really nice fact sheet on COVID-19 testing, and the hyperlink is here for that as well. One thing that you do need to know, if currently in your pharmacy you are not doing flu test or you're not doing cholesterol, the finger stick cholesterol test, you would need to get a CLIA certificate of waiver. So I've included the hyperlink that'll take you to a site that will run through what that is. You had to scroll down about a page and a half, I remember, and it talks about the waiver, and it runs through the process for signing up. So the one thing we don't know is we have no information on billing for COVID-19 testing. So this is going to have to be kind of a balancing act and something that you as a health center are going to have to look into more in the future. If I can get more information on billing for it through the pharmacy, I'll be sure to post it on Noddlepod, let everybody know about it. Or if any of you have information, get a hold of me or please post it. I would love to see it. So yesterday, the director of pharmacy at the health center where I've been let me know that they had received information from Calderos, and going through it, they had over 100 prescriptions that didn't have an RX number, but in fact had an ICN. And I don't recall right now what ICN stands for, but my understanding is it's a number that is assigned to a claim, and more often than not, it is a clinic-administered drug. So it would be assigned to a patient visit when it is sent to the payer or to the insurer for payment. Like we assign a prescription number, the ICN is used to identify that specific patient visit. Well, we as pharmacies don't have access to the ICNs. We don't really have access to the medical record and the billing side of that, which is often separate from the EMR. And so I reached out to Steve Zielinski from Calderos yesterday, and we had quite a long talk about it. One thing he told me, Grappa is no longer what they'll be using. They have a new platform. There's a hyperlink to the information about that. And then within that, on the drop-down list in the past, you usually had the choice of yes or no if the prescription was used 340B or not. There's about 6 different choices now, and one of them is cannot locate ICN CCN. So if this comes to you and you don't have an ability to get into your EMR and figure out what that claim was and if 340B was used or not, you can mark cannot locate ICN CCN. I pressed Steve twice on this because anytime I see words like cannot locate, they right away go audit, audit, audit in my mind because I feel we don't have auditable records if I can't locate them. And so I really pushed him on the fact that as pharmacy, I just don't have access. It's not that I don't want to work. I'm working in good faith. And Steve said, we understand that, and so do the manufacturers. We've not had an issue with this in the past. If you can access it, they want the information. If you can't, they know you're working in good faith. So just know I pursued it twice with Steve to ensure that if we use this cannot locate ICN CCN, the manufacturer is not going to hold this against us, and it's not going to set us up for a manufacturer audit. That was my big concern. So I'm going to post more. I'll put this hyperlink. I've got a little bit more information I got from Steve. I'll put all that on Nattlepod later today or tomorrow, so look for that. So one more thing, actually 3 more things. The May office hours, the focus topic is going to be sliding fee scale. Basically, it's a new approach to assisting eligible patients get medications at an affordable price. And unfortunately, you'll be stuck with me for the full hour because I'm going to present on this. This is something that Colleen and I have worked through for months, almost a year now, is getting some firm information from the Bureau of Primary Health Care on how best to go about doing the sliding fee or offering discounts or affordable medications to eligible patients. And I think we've come up with a pretty good plan that we feel meets BIFIC's needs, and at the same time, they kind of have encouraged us even, this is the way you're best to do this. So I'm going to present that next month, so I hope you'll all be back for that. The other thing I wanted you to know about was the NAC has a COVID-19 Nattlepod. And right now, there are a number of C-suites, practice managers, clinic managers, other folks that are on this. I wanted to open that up to all of you that are on the line today. If you're interested in being a part of the COVID-19 Nattlepod, please reach out to me or to Susan Hansen, and our emails are here on the slide. Just let us know you'd like to be a part of the COVID-19 Nattlepod, and we'll get you signed up and send the information along to you. It's very nice. It keeps us up to date on what's going on, specifically concerning community health centers and the COVID-19 crisis. It has to do with, the PPP small business loans. There's information from technical, clinical sides to financial to everything in between. I've seen Colleen post 3 times in one day on one topic because she's gotten updated information. So if you'd like to have access to this, again, reach out to myself or Susan. We'll be happy to sign you up. The last thing that we wanted to talk about is the 340B Health Summer Coalition Conference. At this point, we're not 100% sure on how that's going to operate. but I'm going to let Sue Veer jump in here and give us some information as to what she knows and some requests she may have. So Sue, actually, Colleen, you'll need to unmute Sue. I don't have control anymore.
Hi, thanks a lot, Tim. Thanks, Colleen, for unmuting me. And at this point, the plans are still to proceed with a face-to-face live 340B Coalition 2020 Summer Conference. It will be in Washington, D.C., scheduled for July 20th through 22nd. So it gives us a pretty good window of opportunity for us to have a little bit more ability to gather together, as well as hopefully free up some of us for travel. And I'm really excited that once again we've put together a really strong program for community health centers. It seems pretty surreal to be working on anything other than COVID-19 response, but we have put together a pretty good program. Developed a pretty good program, which includes, in addition to the regular session roundtable that Colleen typically leads, which it gives us an opportunity to get updates on policy reimbursement, a lot of operational issues. We again have 3 sessions that are called CHC Expert Sessions. The first one's going to be a fast and fun format. It's called Blind Dating 340B Style. More to come on that, but basically it's going to allow 6 experts with best practice models to give a lightning round summary of their best practice models, and then leave lots of time for people to pose questions and really put them in the position of a resource that people can go to if they want to follow up on that best practice model. We're going to do the second session is going to be a very in-depth session on clinic-administered drugs, using 340B for clinic-administered drugs. And not surprising to anyone, the final session will be on the role of pharmacy and rapid adaptation of pharmacy programs in response to a public health emergency. So that doesn't surprise anyone. And so in terms of the assistance I would like, I'm going to go ahead and post the summary of the sessions on NautilePod probably tomorrow. And any feedback you can give me about questions that you think need to be posed. I'm still looking for 1 speaker that I know of, actually 2. I could use someone who has some experience in adapting to this emergency in a contract arrangement. So working with your contract partners to adapt your pharmacy program to maintain access while mitigating risk for your patients. And then secondly, if you have an excellent program where you're using clinic-administered drugs and have good tracking mechanisms in place, please let me know if you'd be interested in being a speaker. With that, thanks, Tim, for giving me a few minutes to talk about the conference. And I am really hoping that we are all able to gather in Washington. I think there is a chance that if that doesn't happen or can't happen, we could see this being converted to a virtual format, but I don't have anything official on that at this point.
Great. Thank you so much, Sue. All right. Well, here is the SurveyMonkey link. So we ask all of you, copy this, click on it, whatever you need to. I'll put it over in the chat, and so you can pick it up from there. It takes virtually 10 seconds to do this survey. It really helps us demonstrate to BIPIC how much value everyone receives. So please, please, please do the SurveyMonkey. Thank you. So now we're going to turn this over to Cengiz and allow him to run through his slides on 340B education for FQHC staff. He and I went through these yesterday, and I think you'll really enjoy his presentation. So, Cengiz, I'm going to slide it over to you, and if Colleen is already unmuted him, you should have control, Cengiz.
All right, perfect. Can you hear me, Tim, and everybody?
Yep.
All right, perfect. So we'll jump right in. Our contact information is down there on the right if you need that. And these buttons are miniature on here, so give me a second. I have nothing to disclose, and the general disclaimer for any presentation, you want to check with legal counsel, Pexis, or HRSA before you make any changes that might impact compliance. A little bit about my health center, and I apologize, when I formatted these slides in the beginning, it was more of a square, so they're kind of adjusting themselves to the rectangle. Our health center serves about 48,000 unique patients annually, and 35% of those are uninsured, 43% are Medicaid. We have 11 medical sites, 3 dental, 3 vision, throughout 2 counties in central Ohio. We have our primary care, behavioral health services, and then clinical pharmacy, dietary, nutrition, substance use disorder, physical therapy, and others that I'm sure I'm forgetting. We also, our 340B program is contract pharmacy only. We don't have have any entity-owned pharmacies at this time. Since we're talking about education of staff, I want to give a brief overview of how ours looks. So we have about a little over 315 total employees. 70 of those are prescribing practitioners, including our clinical pharmacists. In the state of Ohio, we have collaborative practice agreements or consult agreements that allow for the pharmacist to prescribe for certain disease states that are agreed upon. Within our pharmacy department, we have clinical pharmacists, 3 full-time and 1 part-time contracted, as well as a full-time, essentially, PGY2 second-year pharmacy resident for ambulatory care specialty. Our 340B team consists of myself as the program manager, and I split my time. I do see patients one-on-one in clinic, or in this case, via telehealth, for 2 days a week, roughly. And then I have a 340B coordinator that's full-time, whose primary roles are audit champion with compliance, as well as inventory management and working with some referral claims and specialist claims. And then also we have a support specialist who is our champion of the day-to-day troubleshooting and medication access operations with our contract pharmacies for our patients, making sure that we can get streamline the access to medications through 340B. Who needs educated on 340B? The first groups that come to mind are the pharmacy team, the 340B team, or the oversight committee, and then, of course, your prescribing providers. But what we'll talk about is really, the reality is everyone, at least to some extent. This program for a lot of health centers is something that, it's one of the most sustainable foundations of a health center as far as consistent funding. And so, when we talk about everyone, when your patients have questions, who are they likely going to ask? They're going to ask your staff on the front lines, and if your staff have questions, who are they going to ask? So, can you generate 340B savings and never educate a single staff member outside of your 340B team? Sure, of course you can, and I know there's some entities where they just can't get around to it, so that's almost how it is. But there's a lot of lost opportunity for your organization and for your patients that can be optimized if you have staff education. Your 340B program, staff education should be essential for that optimization. Your frontline staff are your eyes and ears and have direct interaction with patients. So how your patients know how to take care, or how can your patients know how to take advantage of the 340B program if your staff can't explain it to them? So my goal is to create and train our staff to be 340B advocates in the clinic and also throughout the organization. So when people are making decisions or they're looking at workflows and all that, automatically the people are, at least in the back burner, thinking, well, could this impact 340B? What would that mean? And start building those conversations. I'm going to go into some types and frequencies of educational sessions that we do at my health center. So the first is new hire orientation, or NHO, as I'll refer to it. And the audience for this is, we focus on any new hire, regardless of their position. For a while, it was a time where I only met with the prescribing providers who were starting on new, and then allowed any other staff that were coming on. I just educated them through the lunch and learns that we'll discuss and other avenues. But really, when we changed it to any new hire, I think it really helped optimize the setting the foundation of discussion around the program and answering and correcting misconceptions early. So I usually spend about 30 minutes in new hire orientation. We do our orientations monthly, and it's a consistent week each month. We don't have out of cycle orientations. If you're going to be hired, you'll go the next month on a certain week with everyone else. And so we go through an intro to 340B, the purpose, our actual cash program structure, what we're able to do for our patients, describing the options through our contract pharmacy network, and the big thing that we focus on is the program impact and how we use the 340B savings, and then of course compliance, and then I also, as I'll describe in an example later, use key points regarding their particular position or role that can help, have some takeaways for them at the end of the presentation. The other thing we do is 340B lunch and learns, where myself and the other 2 members of our 340B team will bring lunch and travel to the individual health centers and speak with their clinic staff and try to get them all together at once. And with this, we spend 30 minutes as well, very similar type of presentation as new hire, because the main focus, and I think the biggest utility of something like this, is the 15 to 20 minute question and answer Q&A after. That is when the Q&A is your chance to capture misconceptions early, to give answers to real life scenarios at the clinic. When you have a support staff, an MA who thinks a certain way, but that MA works for a provider who thinks a different way about how 340B works, you really can get everything out in the open and clarify those things on all levels. And so that's very valuable. I say we do it quarterly with an asterisk because the first 3 quarters we do it and travel to each site, or we at least try to. Coronavirus has thrown that for a loop, but the 4th quarter, as you'll see below, we do an all-staff meeting. The 3rd row here references our pharmacy meetings. And so for our pharmacy meetings, we have our clinical pharmacist, the pharmacy resident, 340B team. Those are monthly meetings where I provide updates, troubleshooting 340B issues when embedded in the clinic, and then navigating common PCP questions. So what I try to do is, since I realize that not everyone is as big of a 340B nerd as I am, I try to pick the big things that our clinical pharmacists, when they're embedded in the clinics and seeing patients and answering questions from providers, how can I make them the best 340B advocates to field some of those questions to maybe be able to handle that at the clinic level instead of going back through the channels of communication to the 340B team that we'll talk about later. The nursing meetings, I try to go to the nursing meetings, which includes our LPNs and RNs, at least twice a year. Lately, it's, when we went through our med room revamp for clinic administered meds, it was definitely more frequent than 2 times a year. Usually spend about 15 minutes with 10 minutes Q&A, really going over clinic administered meds, and you'll see the acronym CAD for clinic administered drugs when further on in the PowerPoint. But I go through workflows, their role, their particular role in the compliance with diversion, duplicate discount, and the importance. I think clarifying for them, what's 340, why we're doing all of this. We have the 340B rules and guidelines. We have our, your state board of pharmacy and all this. So clarifying their questions and making them feel comfortable with a plan that allows them to remain compliant without, totally overwhelming them. And in regards to our pharmacy or our nursing meetings, the lunch and learns, the new hire, I do give handouts at each one, and that could be copies of slides or a printout of, of our contract pharmacy partners or the workflows with screenshots and that type of thing. I do see a question here from Colleen about, do we provide food? We do provide food for our lunch and learns, and we do bring them. We used to have the site decide how that would work. and then we kind of centralize it with the same same restaurant each time to streamline that and keep costs down. And then the all practitioner meeting, we used to have them monthly. Now they're every other month. But it's all of our providers within primary care, women's health, dental, vision, pharmacy, behavioral health, PT. I usually it's a full agenda, so I try to sneak in for at least 10 minutes plus 5 Q&A for targeted topics. So that could be prescribing on our cash program formulary, trying to remind people that every quarter, 50,000 NDCs could possibly change their price, and how that we navigate that to figure out our formulary, and how it doesn't always go day one of the new quarter that price file is updated, and we can just begin that process. There's usually some delay. So communicating that, setting healthy expectations, and I know some providers would why can't we just keep the same formulary for the whole year, and managing those expectations. Talking about prescribing practices, if you would prefer, and we see benefit in a 90-day, looking at 90-day supplies for maintenance meds or other considerations, that's something you can address there as well. And then annually in the fourth quarter, we have our all staff meeting where all 300 plus our staff members meet. I usually get 15 minutes, and I use that to review the purpose, the program updates that might be happening. Did we extend to a new chain pharmacy, or are we doing something different with our cash program, that type of thing. But I think the big impact of that is the overview of the program's impact over the past year, not just the impact of the organization and what services that it's sustaining, but also the impact to our patients and how we've been able to save money for our patients with the cash program. Additionally, I like to flip the script at the end of the presentation, and after we talk about all this impact for these services and what it's sustaining and the impact to our patients, and then basically turn it on the audience and say, all of this is possible because of every single person that's sitting in the room. 340B is a program that's operated by a small team, but we would have nothing to operate if it wasn't for our staff on the front lines communicating these opportunities with our patients, recognizing when someone has a hardship and they just lost insurance for whatever reason, COVID-19, layoffs, everything, and being able to connect them with the 340B resources to make sure that they don't have to go without their medications. Those are things where our 340B team can't be in every single clinic with every single patient, and we rely on empowering our staff to do that for us. And so I like to make that clear to our staff every year. We also do, for our internal 340B team members, I have them do the 340B University on Demand, have them retake it every 1 to 2 years, depending. And that's ongoing, and included a link for where that is. I do give policy updates and high-level 340B items to our oversight committee, as well as our senior leadership team. SLT is senior leadership team, or otherwise known in other places as the C-suite, CEO, CFO, COO. And that really varies on the need. And so if there's certain policies that come out or any national and state legislation that could have an impact, I like to be proactive about explaining that so that there's no surprises when anything actually happens. Or if there's something we can do, like write letters or reach out to legislators, then we can connect with our state PCA and get that started. 340B Coalition conferences. So this is a conference that Suvir was referring to at the beginning of the call. Right now, it's just me who attends. It's a 2.5-day conference twice a year, and I hope one day that we'll be able to expand it more than just me within our with our organization. But what I encourage for anyone who does go to these conferences, I really would encourage you, when you take back ideas. So, for example, I take back ideas and I make it clear to my C-suite when the good ideas that we're implementing come from the conference and come from the people that I met and discussed with at the conference, or come from the session at the conference. You want to show the value in attending these conferences and what it means for program performance and compliance. So I try to make it very, very clear when things come from opportunities that I was afforded because I was, attended those conferences. Travel sometimes can be expensive, but when you think about the grand scheme of things, even the NAP conference with 340B sessions, there's a lot of benefit that I think you can highlight. Apexis 340B University Live. We try to get our 340B team members, if possible, and our senior leadership team if they're attending the conference. It's an 8-hour day. There's information there. They've already talked about it. So I include that little cartoon at the bottom about 340B overload, and it can seem like that sometimes. I was talking to a colleague at Hannah Rell from Erie Family Health Center, who I'm going to share her example of a quiz later on. But we were talking about her calendar and my calendar, and they matched up a little bit. Actually, a majority of it did, and we both agree on the method of exposing people to these basics and the 340B intent and all that many times in a variety of settings throughout the year. And really, we should be living for those aha moments from staff, even if it's just one person in the room at that clinic when I do a lunch and learn, or if I can catch a misconception early or a misunderstanding and correct it, it would be good. And I think it's worth it for sure to get that and help with the eyes and ears of the organization. Tailoring to your audience. So at the end of each slide deck, I try to provide a summary of key points related to the role of the audience. So I included some screenshots of some examples I've used and other things in the past. Is, for prescribing providers, I want to remind them, write 90-day supply. E-prescribe the controlled prescriptions whenever possible. It's preferred over print, fax, or phone. I don't know what EMRs you all have, but sometimes it can be difficult to track things if it's not e-prescribed as far as how it's recorded or how someone documents. Reminding them when a medication is not covered on a patient's insurance, before they switch a med from insurance or request to switch from insurance to 340B cash program. They should be making a good faith effort to choose that preferred drug or complete the prior auth. And I explained to them earlier in the presentation the three of the big reasons why. The first being, we are required by BIPIC to maximize third-party reimbursement whenever possible. But also, the patient impact. If we switch them to 340B, it might be a cheap copay, but that doesn't contribute to their deductible, right? The provider impact. If we had that, that med is on the insurance for a few months throughout the year, and all of a sudden it's switched to 340B, it might impact the star ratings for med adherence for that patient, or the provider star ratings based on the managed care adherence. And then for the entity, the entity could lose on three fronts, right? So we're not getting savings from the insured prescription, but then we might even potentially be using savings to subsidize if they qualify for sliding fee. And, we lose that adherence metric impact for any end of the year bonus incentives for managed care. So there's a lot of reasons, and I go over that, in prior presentation, but at the end here, I just give a reminder to, of the key points, and then recognizing when they may need a patient may need a financial hardship waiver, making sure that they have proof of income on file. For our support staff for the providers, that's what DPS stands for, direct support for provider support. Recognizing barriers to medication access from patients, when to inform the PCP, and when to recognize that patients aren't using a 340B pharmacy, offering and explaining the benefit of it to the patient or the organization. Some helpful tips, and I'll hurry up here, and I want to make sure I leave enough time for questions. We got a little bit more to go through. I continuously update the slides after each session. So I listen to and I try to take notes or have someone else take notes of the questions and comments from each staff. And as soon as that session's over, I revisit the slides and I try to see, was there a question because I wasn't clear enough, or did I not cover it? and then I try to update those slides. And my goal is to routinely review it and be clearer for next time. I want my slides and my handouts or other things, anything that I talk about, to be useful for patients, or I'm sorry, for the staff to have, especially things that are in relation to describing our cash program. I also have looked at creating a running list of FAQs and updating that after every education session. And then you can post anything like that on your shared or intranet drive. A big thing I like to talk with people is, and emphasize, is that your education should not stop after you give your presentation or meet with your staff. You want to make sure that they know how to reach you, and you want to encourage and empower that they should feel comfortable contacting and communicating with the 340B team. When you have an optimized flow of communication, that's your chance to increase awareness of issues before they snowball. That's your chance of streamlining medication access for patients. And it's an opportunity to correct any misconceptions early. So what we've done and steps we've taken in that direction is sharing an EMR inbox for our 340B team. That way staff, when there's an issue, an MA or an LPN doesn't need to remember who is on the 340B team. They can just know, I got to send it to the 340B inbox. We also have a shared phone extension that when they call the extension, it rings to all of our desks. Now we'll jump into a competency quiz. A competency quiz, or a mini quiz, knowledge check. There's a lot of options for this. It's not everyone does it, and so a lot of things I've laid out for you. We were actually looking to implement something like this organizationally wide, and it got put on the back burner when some other priorities took over recently with the coronavirus. So working with HR to streamline that is on the back burner for now. So I have another example from Hannah that I can show, and she's been graciously offered to share that with everybody. So who should be taking these quizzes? And it's really up to you. It could be just your internal team members, your oversight committee, all employees. If you're doing all employees or your team members, you might want to consider different quizzes depending on the staff type. And we'll talk about that when we look at Hannah's example. How should it be administered? You could do paper, you could do an online survey like SurveyMonkey, for instance. When should it be administered? At new hire, you could administer right after new hire to be sure and correct any misconceptions. Immediately after the Apexis University, annually for certain staff. And what should they be quizzed on? The basics of the program intent and the purpose, I think getting that across is key. Patient eligibility, of course, and then compliance consideration. But what I want to make clear is when you are creating these questions, you want to make sure the compliance considerations are specific to how you do things at your health center. So when you look at other people as examples, they may be carving in or carving out, and that may be different than how you do it at your entity. So you don't want to just take everything verbatim. You want to tailor it to your health center. I think a good question to include, no matter who is taking the quiz, is employee use of 340B drugs and proper clinic administered drugs and the material breach. I'm talking fast to make sure we have time for Q&A, so I apologize. So this is Hannah's example quiz is on the following few slides. You can access it at the link below on NoddlePod. She's posted it there for everyone to look at and download. When talking with her, she's the 340B program manager at Erie Family Health, and she said she gives a quiz one time a year to her internal 340B team members. That consists of pharmacy, clinical, purchasing, and finance. She began with a paper format and has moved to the SurveyMonkey. So if you look here, it covers the intent. It talks about diversion and duplicate discount, but if you look at her specific questions, it is specific to the health center. So, what's Erie's greatest diversion risk? Within Erie's 340B program, what is an example? And so you want to get them challenged to think, especially if you're internal 340B team, challenged to think, what can I expect to look out for? And then the responsibility for program compliance, another good question. Patient eligibility. For question 6, it refers to the closed loop for referral scripts. So obviously, outside of your 340B team, your MAs or LPNs that aren't involved in this wouldn't, need to be quizzed on that. So just, if you're looking at doing it for all staff or some staff, just be cognizant of the audience of the quiz. And then she also discusses the employee use of 340B drugs. And if you notice, some of these are open-ended, which I think is good to capture thoughts and conceptions to correct any misconceptions. And Hannah will be available to answer any questions as well during the Q&A portion. So that will be that'll be good. The resources. So we talked about Apexis 340B University on Demand. Link is there. If anyone remembers an old Brainshark video by Apexis, it was like 340B, the basics. They had an old Brainshark link, then another Brainshark link, and then it went and showed an error. And Tim has been great and took initiative and figured it out with Apexis of where that video is now located. And so if you scroll down to the bottom of the page of the link where the arrow is, it's all the way at the bottom. And this is a 12-minute video that's really good for people who just, maybe people on your oversight committee who don't necessarily need to take the whole 340B University on demand, but, you can have an intro video for them that is already there with accurate information. I think it's great. Then there's the Advanced Operations Certificate. There's a fee associated with this course, but I've taken the course. If you're highly involved in your 340B program, I think there's a lot of benefit to that you can bring to the organization by participating in it. And work. It's not something that you can do in a weekend. There's a lot of effort that goes through a lot of different entity types, and so some of it is hospital focused. So you want to make sure that it's something where you're ingrained in 340B, and you may have to apply things to a hospital setting in order to pass the final exam. But knowing if you do 340B every day, you'll quickly be able to shift that and pull out the things related to FQHCs. It's a great program. If your HR uses Relias, I included this here because I'm pretty sure it's a pre-populated Relias webinar. So if your organization uses Relias training, you can request access to a 340B drug discount program for FQHC webinar, which has been helpful. All right, and so at this point, we will open the floor to any questions. I saw the chat was booming, so I decided to let you filter through that, Tim, to help me out here.
I have a lot of the questions have had to do with registration right now. What I think I'd like to do is, let's see, nope. Colleen, can you undo Hannah Rowell's, unmute her, please? She's an AAA.
Yep, doing that right now.
Thank you.
While I'm doing that, Janice, I had a question though. Like, what type of buy-in did you have to get, or how did you get your C-suite to give you this level of access? Like, that it's included in all of these different organizational activities. I know a lot of organizations where you just, when you say, oh, this needs to be included in the board training, or 340B needs to be included in this or that, you get pushback.
Yeah, that's a good question. And one of the things that we did, we started these lunch and learns, and we think the lunch and learns are helpful, but we had no proof, and that was the thing too. We're also taking money out to provide food and staff training. And so what we did is we sent out a Survey Monkey to our staff, asking them, because we at one time we did a newsletter and some other things, and what they came back with was the most impactful was the lunch and learns, and also the chance for Q&A and getting and applying those scenarios to real life situations within the health center, and doing it with the same people that all of our, that each clinic works with that same staff every day. So getting those scenarios out in the open was good. And so once we had that proof through the results of the Survey Monkey, I think that allowed for some leverage to continue it. We were doing it at first, I think, once or twice a year, and then we moved it to 3 times a year. And in regards to the new hire, we found that provider feedback showed that they were confused about their role in 340B, and that was consistent feedback they were giving a few months after hire. And so when we started ingraining it into NHO just for the providers, it was actually my CEO. I met with her, and I was in her office, and I was telling her about different initiatives, and it was actually her idea to expand it beyond it. And I think my constant communication with her, Charlia Tavares, in showing the benefit, and she's big on correcting misconceptions, and so she was all for the expansion. So I think including the C-suite in those discussions when you meet with them about the benefits and having the proof, sending out a survey, asking your staff what works and what doesn't. But I know we made sure to leave time for Q&A, because that was the most helpful.
Thanks. That's really helpful. But you came up with the idea of the lunch and learns on your own and figured out how to finance them on your own out of the pharmacy budget?
Wasn't just myself. There, as a team, there was our department did come up with that. It started as just going to the health centers during their they have like monthly staff meetings, and then what I guess was found was that the 340B discussion was taking up all of the agenda. So I believe it was a way for us to do a separate meeting dedicated solely for 340B, and to guarantee that people would come, offer the food. So, yes.
No, food always helps, but thank you. That's really helpful. So, okay, Hannah, your line should be open now.
Hannah? It's still red, Colleen.
Is it? Okay, try again. Sorry.
Hey, this is Hannah Rowell.
There you go.
Hey,
okay.
Hannah. I really like your quiz, and I was just wondering, is this something that you kind of switch up a little bit each time you give it, or is it pretty standard every time?
So we gave it last April on paper, and then we just did it this week. So we're doing it annually, and we moved to Survey Monkey because we're social distancing. But already most of the team has responded, and some good answers. I'll echo, I think that having a few open-ended questions is helpful, because it's just nice to hear how people explain the congressional intent and things like that. So we've only done it twice, but I only changed maybe like 1 or 2 questions this year.
Okay, because those are still always going to be the key questions.
Yeah.
So to everybody on board, this is under in Nottopod. I'm trying to think what the topic is. Probably employee education or employee quizzes. I can't off the top of my head think.
Or something, yeah, something like that.
So
it was initially a
suggestion
of our auditor.
Yeah. Okay. Or you could just search for the word quiz in Nottopod, and it should pull it up.
Yeah.
Right. On the upper right is a search box, and if you just put quiz in, you'll bring everything up. Another quiz, actually, Julie Kohler, the director of pharmacy at the health center where I am, she put together a math quiz for her technicians that was really good. It was pretty simple, and it was standard pharmacy math. and I think only one of them got every question right. So she has also posted that. I think it's real handy to quiz our folks and make sure that their competency is where it needs to be, both on 340B and general pharmacy. But Hannah, thank you so much for sharing that. If any of the rest of you put together some quizzes like this, please post them on Nottapod. All you have to do is a new post, and at the bottom right, click Add Attachment and add your attachment there. And if you can, put it in as a Word document. That way people can copy and paste it easier. If not, that's fine, but please share with the rest of us out here. Hannah, there was a question on whether you could share your study guide.
Sure, yeah.
And
it's just a Word document with all the key answers, basically.
And then the other thing was, does all the staff take that, or is that just for your pharmacy staff?
So that's just for our 340B team, which is a mix of finance folks, pharmacy, our clinical advisor, myself, our purchasing department. So it's our kind of core 340B team that meets monthly. For all staff, similar to Jengis, we have a whole education calendar and a required all staff meeting that they just need to attend. They don't take a quiz for that, but the attendance is required.
One thing that when Hannah and I were talking, that she mentioned that her external auditor thought it would be a good idea to keep the documentation of her educational calendar because it helps speak to all the attempts at compliance education across the organization. And I think I just want to echo that, Hannah, that for everyone, I think that's a great idea.
Yeah, because it helps you remember all the things you're doing across the year. And also just as far as, I would say, making relationships is important. So I'm constantly trying to keep 340B in favor with the different folks who schedule the nursing meetings or provide our grand rounds or wherever you need to get on an agenda. You kind of have to build those relationships over time. So.
Great. There was a question that came regarding ensuring that prescriptions at contract pharmacies go through insurance. That went to Colleen Myman. If the person who put that out, if you'd email me directly, we'll set up a time to talk about that. So please email me directly with that question. Let me see about any other questions here.
Hey. Tim, I just shared your email address there.
Okay, perfect.
So other people can share with you. Also, I see a question that came in. Candace, reach out to Tim or me about Nottapod, but I saw a question came in about, and this one I'm not familiar with, California ADAP enrollment, moving to, looks like cost plus dispensing fee. Not familiar with that, but I do know that the budget that was just passed by New York State moved all of their pharmaceuticals and Medicaid to managed care, which meant that they've lost the ability, or excuse me, to fee-for-service. They've lost the ability to retain any 340B, provide any 340B savings on their Medicaid managed care drugs, which I think the title of the email I saw was as if New York health centers didn't have enough to worry about already. So, and please just
that
know
won't be
NAC
implemented for a little while.
For a while? Okay, well, maybe something will happen.
We have a chance to fight it. Yeah.
Good. Good. And just please know that NAC is watching carefully here. We're concerned that with all of the push to get legislation passed in given the coronavirus, that people could sneak things in that could have unintended or intended but kept secret 340B impacts. So just please know that we're watching very carefully for that because we don't want something to get snuck in there on a must-move vehicle. So that was it for me.
Well, everyone, thank you. Jengis, thank you so much for preparing for our focus topic today. Hannah, thank you for entering in as well. Colleen, keep up the good fight. Try to get those 2,000 emails out of your inbox, and we appreciate everything all of you across the country are doing for your patients and your communities. So we will meet again together next month. The topic will be sliding fee scale. Thank you again for being here. The SurveyMonkey, Hannah posted again. Please just click that link. It's 4 quick questions. Thanks, everyone.
Thank you.
Thank you, Tim. You're a lifesaver. Bye.
Yes, thank you.